On from my end.
All righty. Perfect. Hi, everyone. Welcome to the MIT Club of Northern California's Frontline series. I'm your host, Julia Yu, MIT class of 2010. And today we are delighted to have Dr. Sudeb Dalai as our special guest. Dr. Dalai is an MIT class of 2002, an infectious disease physician, virologist, an epidemiologist at Stanford University School of Medicine and Palo Alto Medical Foundation. He is also a medical director of Karius, an infectious disease diagnostics company. Dr. Dalai has been at the forefront of the COVID-19 pandemic as a treating physician. He is very much a real-life disease detective, especially with his unique combination as an epidemiologist and infectious disease doctor. We are grateful to have you with us here today.
Julia, thank you so much for having me, and I appreciate that warm introduction. Just to tell you all a little about myself, as you mentioned, Julia, I went to MIT as an undergrad. I was class of 2002 and course 9. And among other things, I was class president my junior and senior years, and then I served on the MIT Corporation from 2003 to 2008. I came to Stanford for medical school, and in the middle of that did my PhD in epidemiology jointly with UC Berkeley School of Public Health, where I focused on virology, mainly in HIV. I then went on to do internal medicine residency and infectious disease fellowship at Stanford. So currently I wear several hats. As you mentioned, I'm an infectious disease physician at Stanford Hospital and Palo Alto Medical Foundation, where I see both hospitalized patients and critically ill patients, COVID and non-COVID, and I have an outpatient clinical practice in infectious disease. I'm on the faculty at Stanford School of Medicine, where I teach courses in epidemiology and genomics and virology and public health. And as you mentioned, I'm also medical director at a Series B startup company here in Silicon Valley, which develops innovative diagnostics for infectious diseases. So, you know, in many ways, coronavirus somehow ends up being the exact type of thing that I trained for as an infectious disease physician and virologist and epidemiologist and a diagnostics person in industry. So I'm very happy that you asked me to join, and I'm happy to chat about the various lenses through which I see this pandemic, particularly being on the front lines and sort of beyond the front lines also.
Thank you, Dr. Dalai. That was actually my first question for you. You wear many hats as an epidemiologist, as an infectious disease doctor, and even as an entrepreneur, right? You're in a unique position as you study these infectious diseases, and now we are living in a real life pandemic. Like you said, you've been training for this all your life. How is it? How is it wearing all of these hats and seeing the pandemic unravel?
Yeah, that's a great question, and I would say that the two personalities there, so epidemiologist and infectious disease physician, they're not so much like Jekyll and Hyde. They're not so much in opposition, but they're more kind of like husband and wife, I would say. So the epidemiologist in me was absolutely terrified, to be frank, sounding the alarm bells like everyone else very early on in this pandemic. When we heard about it in November and we started seeing an explosion of exponential growth in cases in December overseas, because we study and observe epidemics all the time, and all the numbers available were telling us that no matter which model we used very early on, this would be a horrifying pandemic and hundreds of thousands of people would die and hospitals would be overwhelmed fairly quickly. That we knew very early on. But at the same time, you know, the physician in me actually knew that we could handle the patients as long as we had staffing and beds and equipment. This is not a particularly complicated illness to deal with, although the lack of natural human immunity and lack of any treatments were concerning and somewhat discouraging. But nonetheless, we've seen much worse infections, and my sickest patients throughout this unfolding of the global pandemic in the hospital are still largely my non-coronavirus cases. I will say, however, that this illness is quite unique in the sheer length of time that it lasts. Both people who are quarantined at home as well as people who are in the hospital who stay for 3-4 weeks, maybe even longer in the ICU. And that's relative to the respiratory virus infections. So I will say that being in that unique position also equipped me to be a resource and to serve in a variety of settings. There was a lot of outreach, certainly from public health institutions in our area early on, the two institutions that I belong to medically, as well as patients and other doctors. And so, my phone battery is dead by the middle of the day, and it's a brand new iPhone actually. So it just sort of rings, and I get messages quite commonly throughout the day. So I helped hospitals here develop protocols for accepting and managing patients as soon as they walk in the door, develop outdoor testing sites, and we raised tent and drive-through testing sites at both institutions to build surge capacity. That's largely my epidemiology role. Then there was the drug sourcing and management of individual patients, and I helped develop algorithms to triage and treat patients in the hospital. And I'm actually a co-investigator for a Stanford trial of remdesivir. I'm sure many people have heard of that drug, which started from the very beginning of the pandemic here. And that was more of the infectious disease physician in me. And then there's the volume of phone calls that I mentioned, and I consider that an important public service because there's a lot of anxiety certainly about this pandemic, and there are a lot of answers that I hope to provide to other individuals who are worried about their own patients. So you're right. This is what I studied, and this is what I trained for, and certainly I'm always worried about it. But we never expected something of this magnitude to really arrive, and so I would say that it's perhaps the most challenging moment for healthcare in our generation, but it's also been in many ways healthcare's finest hour.
Great, and I hope your cell phone is fully charged because we don't want to lose you during this webcast.
It is. Thank you.
You touched upon testing. Right, and I want to go back to this topic. Stanford was one of the first institutions to do their own testing. Tell us more about the evolution of testing and how far we've come from where we were and where we are today and where we're going.
Yeah, that's another excellent question. I'm sure, as you all know, early on, there was a huge deficit in the availability of testing. Very early on in January, when we started to see our first cases in the United States, we would have to call CDC directly. And unless our patient met very specific criteria regarding travel to known epidemic hotspots, the test would get denied. And we now know, looking back, quite frankly, that that was a mistake because the virus was already here and already being transmitted in this country beyond individuals who had just traveled to high-risk areas already by that point. And so then when CDC evolved to start sending tests and test kits to states so they could do their own testing, our public health lab in California received 1,200 tests for the entire state of California. So we knew at that time that there was a lot of limited capacity and the numbers were woefully inadequate. And that was also quite discouraging. And still then we had criteria for who needed to get tested and who would qualify. That wasn't even enough tests for Palo Alto, California. So at the beginning it was quite limited. And then industries and medical centers began developing their own testing. And as you mentioned, Stanford was the first institution nationwide to develop and launch their own in-house testing. That was done in our hospital lab here on the campus. And that quickly ramped up in capacity to do 1,000 tests per day. And that was initially restricted to healthcare workers, then expanded to anyone who had an order from a physician recommending they get tested. And now we've included, as of last week, antibody testing in-house, and we can run 2,000 of those tests daily. And so, looking back, I absolutely do think that we could have done it differently, but it would have involved a lot of foresight and a large investment up front in having large-scale testing capacity and materials. So I would say that our experience at Stanford has been, as it's been with other illnesses where we develop tests, the development of the test itself is not complicated. It can be done in about 1 to 3 weeks. And so once that's validated, any laboratory that's capable of running PCRs or genomic-based tests at scale can be part of that scale-up effort. And so the diagnostic companies such as Cepheid, Abbott, Roche, Quest, and many others have really stepped up when it became clear that CDC would be unable to handle this effort. But it really requires a large investment up front in things that could happen and the scale up of tests for situations that could occur. And unfortunately, that's not the situation up to this point regarding US healthcare. We are a reactive healthcare system, but I think we've learned a lot of lessons certainly from this current pandemic.
Right. And I know we touched on the rear view mirror a bit. How do you think that we collectively as a nation could have done testing differently?
Well, I think what we learned and what we already knew is that industry innovation and scalability, the ability to rapidly develop and distribute diagnostic tests, that capability far exceeds what public institutions, including the federal government, but also including universities, are able to provide. That's really just the math and the numbers. And that's whether you're talking about the resources and the billions of dollars that industry has to put weight behind these kinds of measures or connectedness with the general population in the form of private labs that are highly connected with patients, and the extensiveness of network and reach, and also, quite frankly, the agility of private institutions to pivot and rapidly switch to developing a new test based on technology they developed for old tests. And so we learned that from this pandemic, but we largely knew that already. So federal investment in and also incentivization of these efforts will, by default, I think, enable coordination when it's needed. So we'll be better prepared next time, I hope. But that partnership needs to be prioritized, and that starts with recognition of diseases that may not be present or expensive at the moment, but have the potential to be devastating. And this has really been the hour where epidemiologists and infectious disease physicians have had the public voice and the attention of media, the news media and social media, the attention of Congress, the attention of the stakeholders. And so for these kinds of situations, I really think we should have disaster preparedness, because that's the mentality that it would take to make these kinds of investments for things that could potentially materialize.
And do you think there are other countries out there? There's a lot of talk, especially in regards to testing, of South Korea having been very proactive. Do you think there's lessons we could take from other governments and how they have reacted or have been proactive that we could take away?
Yeah, that's an excellent question. There are certainly models of distancing and isolation and mobility control in many other countries that we can learn from, but at the same time acknowledging that many of those societies are more autocratic than ours, and we certainly value personal freedoms and the lack of autocracy in a way in this country. And so there's a balance there. I think that early on, there were many statements by those countries acknowledging what the potential scale and threat and disease expansiveness could be in their countries. And there were fairly early lockdowns that took place. And I think epidemiologically, that is the most effective intervention that we could possibly provide. One of the ideas that became apparent very early on is that we can no longer contain the pandemic. And so containment was no longer an option. We were switching to a mitigation mode. And it was very clear early on, before the pandemic even reached our country, that mitigation was going to have to be the strategy, because a virus that's this transmissible, with this high of a fatality rate, with of a respiratory nature, probably can't be contained, given the scale of the numbers we were looking at overseas. So one of the lessons is that mitigation, I think early on, probably should have been the priority and the rule, not the exception that we pivoted to later on. And the second thing I would say is that those countries had learned from SARS, where they were directly affected. And that mentality, I think, built into their capacity a recognition of resources to apply toward these pandemics, and particularly the ability to scale up medical institutions very rapidly and raise new medical capacity very quickly. That was something that we were not very nimble at doing. And I fear that now a lot of areas of the country that are being disproportionately affected by the pandemic are seeing that capacity has really been stretched. And so that was, I think, another lesson from the response is the raising of hospitals that could house tens of thousands of cases is something that we should be more nimble at being able to accomplish. And I think that we've learned that lesson as well.
Great, thank you. Speaking of capacity, I want to talk about flattening the curve in this term. This concept has been introduced to mainstream and is pretty widespread and widely understood, but this is a very specific epidemiologic term. Can you explain to us how this has become mainstream?
Sure. You know, it's, I have to say that it was quite encouraging to me that that concept caught on amongst the general population and has been talked about now for several months. So as epidemiologists, we are always talking about epidemic curves and the peaks of these curves and when we expect epidemics to peak and the ways to manipulate or to modify these curves by influencing transmission events. So we talk about flattening the curve, you know, back as far as epidemiology 101. It's certainly a concept that is really easy for MIT alums to understand because the math is quite straightforward. But I never once thought that it would become a term that's commonly used among the general public, and it's advertised now and it's tweeted about and glamorized, and that society would quite frankly embrace. And so all of a sudden, epidemiology as a field and as a science has quite frankly become sexy. Everybody's talking about PPE, and Tony Fauci has been thrust into the limelight as the doctor of the nation. It's not the Surgeon General, it's not Sanjay Gupta, it's Tony Fauci that's really the face of this pandemic and our response. And that is despite the fact that he's been in the same position as director of that institute at NIH, of the National Institute for Allergy and Infectious Diseases. He's been director since 1984. So as an epidemiologist myself who teaches these concepts year after year to undergraduates, I'm quite encouraged that these have now come to the forefront of national dialogue. I certainly wish it had been under different circumstances, but every year, now that we understand these concepts and that we've seen that implementation of these concepts on wide scales can affect really the scale and the unfolding of pandemics, we will be able to save tens of thousands of lives, I feel, each year if the public understands these concepts and exercises them during respiratory virus season. You know, it's very interesting, but not unexpected that as we've seen the flattening of the curve in this pandemic, we've seen flattening of curves in all the other pandemics we expect this time of year. So flu season petered out very early on. All of the other respiratory viruses that co-circulate in this time period also went away. And quite frankly, other infections that circulate in the hospital also were largely mitigated. That's partly due to hospitals having less patients in the hospital, less elective procedures, so there are less people that are there. But certainly there's been a lot more hand hygiene and a lot more caution regarding transmission, and a lot more patients that when they come into the hospital do not have the respiratory illnesses that we would expect in the numbers at this time. So I do think that the distancing and flattening the curve has been embraced, and it's been beneficial, and it's not going to go away anytime soon. And I find that highly positive.
Great. And moving on to another epidemiologic term, PPE, right? There's been a lot of press and hype around how to maximize PPE. But on the flip side, there hasn't been as much discussion on how to increase the efficiency and minimize the use of PPE. Can you tell us a little bit more about your perspective on how technology has been used?
Absolutely. I'm glad you asked that question. You know, everyone has heard about and knows about the PPE shortages, and we certainly experienced that as well, although the risks to us as we were evaluating patients at the time this was happening was concerning, and frankly, it was unfair when it happened. And we quickly found ways, as you mentioned, to conserve PPE and reduce our risk of exposures. So, you know, I will mention personally, it was of concern to me. You know, I'm in a dual physician household. We have an 11-month-old baby at home. And so it was always the thing at the top of my mind when I was in a room with a coronavirus infected patient. It's always going through your mind. You certainly place a lot of trust in PPE in the patient evaluation. and you're relying on that trust, and you're relying on it to get you through and to avoid getting infected. So what we ended up doing was fitting each room, actually COVID and non-COVID, with an iPad, which was on a mobile arm. And so for patients who didn't need a direct face-to-face evaluation from the physician or from myself, we would call into the room, actually via Zoom, from outside on a console, and we would discuss a patient's symptoms, their progress, and their plan. And so we minimized foot traffic and exposure, and we were able to conserve masks and PPE. And I would say that certainly we were stretched thin regarding the number of masks. You know, on an average day at Stanford Hospital, we use 1,095 masks or more, and that's on an average day. And so now we were using up to tens of thousands of masks per day because of the volume of patients that would need to be seen frequently by multiple providers. I would say that a related area where we leveraged technology quite rapidly was telemedicine, which for some reasons which are a little outside of the scope of my understanding, that was extremely slow to become commonplace prior to this pandemic. So telemedicine and video visits with patients was ramping up in a very, I would say, orchestrated, systematic fashion, but it was quite slow. And it was only being used in a few places in very limited ways. And so each time I would ask my own health system, you know, why are we not doing telemedicine visits? There wasn't really a straightforward answer. And now in the midst of a pandemic where there are real concerns about exposure and the desire to not have patients come into clinic, but at the same time, a need to continue to manage their medical conditions, which have not gone away. We need to continue providing high quality care and keep the system functioning despite the pandemic. And so all the major health systems very quickly provided and enabled video visits through various channels, through the electronic medical record, through Zoom, through WebEx, through Doximity. FaceTime visits all of a sudden became acceptable with your patients, and there were relaxed rules about privacy violations. And so now it's extremely easy to do a video visit with any patient at any time. And I have 5 or 6 platforms that I can use for any patient. And so these are not obviously miracles or huge feats of technology, but it has ushered in a new era of telemedicine and the ability to avoid exposure and guide patients and help them avoid exposure as well, which is a huge advantage for providers and for patients both.
And do you think these behaviors are going to stick? Do you think telemedicine is our future? And this was, in a way, an inconvenient forcing function to get us there?
I do actually think that it's here to stay, and I'm encouraged by that. I think it's been a long time coming, and the feedback that I've certainly received from my own patients as well as other providers is that it has made medical care much more convenient in many ways. And certainly there are a large fraction of patients who have challenges coming into clinic for physical reasons or distance reasons. There are also a number of patients who are so distant that they can't come in to be seen in a timely fashion, whereas a televideo visit can actually gain a lot of ground for those patients. And I often, in my own infectious disease clinic, face one of the large issues that I face is that patients who wait a long time to see me come in after a month of their illness continuing to progress. And enabling a televideo visit to get ahead of that problem very early on, I think could save a lot of morbidity, certainly mortality, a lot of complications of the challenges that they have with their illness. And so I do think that a lot of providers have recognized that. And while it was forced upon us in a very haphazard fashion, and there will certainly need to be restrictions and reining in of HIPAA and other privacy violations to make sure that we're doing it in a straightforward and orchestrated fashion, I do think that it's here to stay. And quite frankly, I think that it's advantageous for a number of ways. The interesting thing about billing is that insurance providers have also relaxed their restrictions, and they reimburse for televideo visits quite similarly to an in-office visit, which has largely been a breakthrough, I feel. And that's, I think, supports the current notion of telemedicine as here to stay in healthcare, now that we certainly have payers that are willing to support it as well.
Great. And certainly it seems like a lot of the regulations and red tape that's been around. All of these things that were impediments before are starting to be reevaluated, which hopefully is good news.
Absolutely.
Great. I want to ask you, you mentioned that you and your wife are both physicians and in medicine. How are you guys doing? How are you guys managing that? Because for us who are staying at home, we have a very different experience. So curious what your sentiment is at home.
Yeah, you know, in many ways, thank you for asking that question. In many ways, there was certainly an understanding, you know, my wife being a physician herself, that this was the moment for infectious disease physicians. And there's certainly a lot of support for me to be involved in any way that I could regarding this effort, including seeing my patients on my own in the hospital, which, as you alluded to, places everyone at risk. And there was certainly an understanding in the household that this is something that was my calling to bring me into medicine in the first place, and certainly my calling as an infectious disease physician. You know, this is an infectious disease. This is certainly something where I have value and felt compelled to add that value in as many ways as I could. So we certainly developed a home protocol for me to be as safe as possible when I am attending at the hospital. And that involves having my own vehicle that no one else drives to the hospital, and a set of scrubs and my white coat that I wear that are located outside of the home. And then when I get to the hospital, I'm masked up at all times. And then I don proper PPE as typical that I've been used to doing for years now when I'm evaluating patients. And then after I've concluded at the hospital, after a few hours, I come home at night. I'm again masked. And then when I get home, there's a chamber that we've set up outside of the house in the garage where I take off everything and then come into the house and then sort of use hand hygiene and then you know, take a shower when I get home before saying hi to anyone and before entering the rest of the household. And so we set up that protocol for me to follow, and we certainly considered more draconian things like separating into different households for the time that I would be attending. And we just decided and made the personal decision that that would be hard, and that I personally trusted in the PPE. And as long as I had proper PPE and didn't have to reuse and had all the proper protocols in place for me to follow, that we would generally consider ourselves at somewhat lower risk. And so we've stuck to that plan, and we've been doing that now the last couple of months. But you know, I think it started with an understanding and a lot of conversations around how to make this workable. And at the same time, we both opened up our practices to telemedicine visits for our clinic work, just to decrease the amount of exposure that we have. I will say that we've isolated ourselves from friends and other family because of the potential risks that we would pose to others. So we've remained, you know, our 3-person unit in the household with our nanny as well helping, and that's been our nucleus. And we haven't, for personal reasons, haven't wanted to expose other individuals. So we've stayed at home.
Wow, that's quite a comprehensive process, and really appreciate you and your wife's service.
Thank you.
I want to ask about previous diseases such as SARS and MERS. You know, today, more than 1 in 7 Americans are out of work, and some Americans are trying to understand, you know, why didn't SARS and MERS shut down the economy? How is this different? Why is this shutting down the economy, and is it worth it? Could you help us understand the difference between COVID-19 from the other diseases, and perhaps what makes this unique?
Sure. To contrast a few concepts with SARS and MERS, those were highly fatal illnesses. The MERS mortality rates were up to 30% or more. SARS mortality rates were 10% or greater. And so the epidemiologic concept would be the idea of fatality and how that works inversely to transmissibility. If you have an infection or a communicable disease that's highly fatal, it does not efficiently transmit because it kills the host quite rapidly. That's in contrast to the cold virus, which affects millions of Americans, probably hundreds of millions of Americans every single year. It's not particularly fatal. It's only fatal for the most vulnerable, but it infects a large swath of the population throughout the respiratory virus season. And it's efficiently transmitted because most people are either asymptomatic or mildly symptomatic. So they still participate in society and recreational activities, they still go to work, they still expose others. And so the transmissibility and the R naught, as we've heard about that term, is much higher. And so, and it's an effective R naught. It's not the actual viral property, it's how effectively that virus in a real setting, in a real population that's mobile and is mixing, how efficiently does that virus replicate and transmit in the population. So with those two illnesses being rapidly fatal, the transmissibility was ultimately not that high. And it was actually fairly easy to contain those pandemics for that reason. So in the case of MERS, it was largely relegated to the Middle East. In the case of SARS, it went in a number of places in Asia, it was largely restricted to healthcare settings, meaning that individuals became rapidly sick and needed to be hospitalized, and sometimes there were hospital outbreaks, but it certainly did not take on a community transmission component that became a large-scale pandemic. And so I would contrast that with this coronavirus, which we know is highly transmissible. The R naught is estimated between 2 and 3. We won't know the true R naught until after the pandemic is over and we're able to do virologic and epidemiologic studies on all the data. But we do know that it's fairly transmissible. We also know that it's not as fatal as those other illnesses. It certainly has a concerning fatality rate, anywhere from 1% to 3% or even higher, which is quite high. That's 10 to 20 times what influenza would have as far as a fatality rate. But it's still not a fatality rate that's high enough that would cause it to burn out in a population rapidly. Instead, for the vast majority of people, they experience mild symptoms or no symptoms, they can still efficiently transmit that virus. There are a few other concepts that are coming to light based on anecdotal evidence and some studies that will lead to larger scale efforts to understand, but we have certainly seen that this virus probably has extremely high viral loads in the nasopharynx, and there are studies that are ongoing to demonstrate that it probably is higher than SARS, MERS, or some of the other coronaviruses, that many patients have an extremely high viral load in the nasopharynx. And then that is a vehicle for being able to more efficiently transmit virus, particularly if you're asymptomatic. And it's also potentially shed in other specimens, such as stool. And so if it's shed in other tissue specimens, then it could potentially be transmitted fecal oral as well as respiratory. And so there's a lot we're still learning about the virology of this particular virus, but it certainly is unique in some regards, and that has lended itself to being transmissible. I would finally add that the fact that it's novel implies that we have no human immunity to this virus, meaning that we have nearly 100%, if not entirely 100% susceptible population. That is not seen commonly with most respiratory viruses, which is why in many of those illnesses, they do not manifest as a severe illness that with such a high fatality rate. So we are still trying to understand why some individuals may not manifest as severe a disease as others. And there's certainly studies that are ongoing to show that there might be receptors on certain cells that certain individuals have and other individuals don't, which is why they get sicker. But that certainly creates a stratification in the US public where certain individuals will be effective spreaders and other individuals will not be. And we're certainly learning a lot of that, but it really does speak to the need for well-designed studies that really help us understand the virologic and epidemiologic concepts that make this illness very different.
That is very helpful, thank you. And because this is a highly contagious respiratory disease, we've been told, now everyone should wear a mask. Could you give us a little more color on this and any tips? I know that you've had videos out there of how to make your own mask. Could you just give us some tips on masks?
Sure. Yes, as you mentioned, there's been a fair amount of outreach to ask for my expertise in mask making, which I've never made a mask, so it certainly was a very interesting question that I received pretty early on, but actually one that I started to recognize I could add some insight to. So I, even before the CDC recommendation that masking should be commonplace among the general public, it was something that I was advocating because the concept of using a mask, we classified that concept as largely protecting other individuals from an infected person, that they themselves wearing the mask would be the main beneficiary of that by not transmitting to other individuals. But I knew in my mind that a mask also protects us from inbound exposure. We know that. That's why we wear masks in the hospital. That's why surgeons wear masks when they're doing surgery, not to protect themselves only from, or to protect the patient from them exposing the patient to something they might have, but also an inbound exposure. So we know that masks work. I do agree that it's probably more effective for the former rather than the latter, but when you have something that is highly transmissible, as you mentioned, any protection against inbound transmission is certainly something that's advantageous on a population level. And when you are talking about millions of individuals who will be infected, then even placing a small dent in that transmission by having everyone wear masks when they go out in public will alter the dynamics of the pandemic to a huge degree. We've seen that even a few days of distancing have manipulated those curves substantially, and the same is true of masks. So then I started realizing that if individuals are going to start making their own masks, there are certainly best practices and worst practices regarding the construction of those masks that would enable individuals to be adequately protected while at the same time not using materials that are harmful or that are likely to be ineffective or provide a very minuscule amount of protection. And so I worked with Huffington Post on a piece to help provide some guidance on best and worst practices. And generally, it is felt, and this is in line with CDC guidance regarding home masks, that using any type of cloth material is better than nothing, but using filtration materials within those cloths, almost kind of sandwiching a filter material of some kind that's not a harmful filter material, probably provides some additional protection. So any mask is better than none if there is a desire to use filtration material. And I would say that for the general population, that's probably not essential, but for certain individuals who either anticipate a higher risk or a prolonged exposure, or individuals who have these underlying conditions that we've heard discussed in the news as well, heart conditions, lung conditions, diabetes. These individuals have particular high risks, probably would benefit from the additional protection that a filter would provide. And out of the filter materials, as I researched it, I realized that certainly HEPA filters that are available in home vacuum bags are an adequate material. And there are other materials that could be used at home as well. But at the same time, there are harmful materials that one could obtain from household supplies, such as fiberglass related materials and other kinds of HEPA filters that are used in air conditioning units that probably put someone at risk of inhaling particles in fiberglass and developing more lung problems, and probably without providing the benefit that we would want. And so I helped provide some of that guidance. And certainly I've worked with a number of companies who are interested in developing sterilization procedures for PPE as well. And Stanford has been rolling out that initiative in-house as well. And certainly there are sterilization procedures that I think will be highly useful and that will help us sterilize our masks and reuse them in a safe fashion. So it's certainly something where I have been, it wasn't something that I expected, but certainly I was happy to help add to the conversation and felt I could add value. So felt compelled to do so.
Thank you. That is really informative. You mentioned a few times that, we know Stanford is doing a lot of great things in-house. Are you sharing any of these best practices anywhere? And what is the collaboration rhythm between the medical community and doctors right now?
Sure. I have frankly been quite impressed with the openness that Stanford has taken to this, and that is, I would say, an embrace of Stanford's spirit overall in making what is known and what is being developed available to the world. So I'll take the example of development of tests in-house. So that was based on genetic information and PCR information that was already provided by CDC, and the rapid development of the testing in-house using our own capabilities was then broadcast very early on. And any institution could either send us a patient test or reach out to us to understand our protocols and how we develop that test so rapidly in-house. So that was something that Stanford freely shared and then rapidly brought forth in media and publications. The same thing is occurring now with antibody testing, where Stanford is supplying the protocols for free for anyone who desires them, and we'll be publishing those protocols as well. And I guess the final thing would be the algorithms and hospital approaches that we have been using. And I'll give you the very direct example of myself belonging to two medical institutions. So in addition to Stanford, I also work at Palo Medical Foundation, which is a group multi-specialty practice. It's not an academic institution, but it is an extremely large health system with tens of thousands more patients and physicians than Stanford. This is as being a much larger organization, I would say it's less nimble, but has a larger outreach and would certainly benefit from information sharing. And in between the two institutions, I found it very easy to share any document, any protocol that I wanted with Sutter Health, which owns Palo Alto Medical Foundation, from Stanford. And there was a very openness in that dialogue and that communication. And actually there were a number of Zoom phone calls that we were on over the last couple of months where we would involve physicians from both sites to share best practices. And I think that that's an example of Stanford helping its neighbor across the street, and in that way helping tens of thousands more patients than could have been helped by Stanford alone. And so I think that that's actually been a very encouraging thing. And it's certainly been duplicated across the country at a number of institutions, and the scale at which peer-reviewed journals have been willing to publish information very rapidly. So I think that there has certainly been an embrace of openness and information sharing. And cautiously, I would hope that that would continue as well. It's certainly been useful for us to get information out there, appreciating the challenges in that approach as well. But it's certainly something that I found encouraging.
That's very encouraging, just the openness and the collaboration. How are your peers doing who are, because you're in a unique position where this is a crossroads of exactly what you've been training for as an infectious disease doctor. But how about for those specialists who are in other specialties that are deemed non-essential? I know that there's been, hospitals are businesses too, and there's been a financial impact on almost every hospital around the country. How are your peers doing with the redeployment of all resources and all hands on deck for COVID-19?
That's an excellent question. And I would say that overall, physician morale is low. And that is precisely because of some of the reasons that you described, that many physicians who do very important work, but in this time of disaster are not doing work that would add directly to patient management or hospital management, have either shut down their practices or scaled back their practices, or are only doing essential things. And so many individuals are now at home, not doing work, not doing the things that they love, not doing the things they've been trained for months. And so in addition to that, watching, there is an inevitable consumption of media and of news. And so watching things unfold on TV regarding the lack of PPE, exposure and death of healthcare workers, many of whom are our colleagues that we know very well, particularly in New York and New Jersey and other places. And those are friends of ours who are getting infected and being put at risk. Also watching what has been, I think, a challenging national response to this pandemic. I would say that the combination of all these things being observed has led to a fairly low morale in physicians, and also a rattling in our faith in the healthcare system. So there are certain things I think that physicians have been holding on to, and certain things that health institutions in our area have been doing to help support that effort. And the first, of course, is financial. And so Stanford and Sutter Health have agreed to support physicians financially through this downturn, even when they are not necessarily working or performing revenue generating procedures. That has come at an enormous, staggering financial loss to the institutions of hundreds of millions of dollars, particularly to Sutter and to Stanford. And the scale is only adding up, and it was something that I certainly was surprised. The magnitude of that loss was not something that I expected until I started reading the news week after week of just the amount of revenue loss that our institutions are facing. And that's something that will probably not be recoverable. When physicians go back to work, they probably go back to their prior level of high productivity, but it's not something that's a deficit that we can easily make up. And so it will be a large financial hit that institutions will have to recover from, but it's certainly something that they've stepped up, recognizing that the alternative, which is having physicians at home, not doing their work, and potentially going into situations that are much more financially challenging for them, particularly new physicians who have a lot of debt and other financial obligations. The institutions have recognized that. And I would also say that there has now been, after this controlled burn of a couple of months, particularly in our area, a coping with this illness. And the ways that physicians have found to cope is to recognize that this is a time to be at home that they probably never had in their lifetime, probably, of training as physicians. It's a time to reconcile and to be with family and to spend time with others. 6 feet apart, obviously, but to spend time working on things that they weren't able to work on before, because this is now protected time in a way. And at the same time, there has been a lot of optimism. And I think the physicians have held on to that. There has been a coming together of the community. There have been collective efforts to collect masks and PPE and donate them to our institutions as well as others. There have been people that have been helping out the elderly. There have been free Zoom phone calls and conferences. There have been meetings and gatherings and yoga classes and exercise classes and music classes. And so there's been a lot of optimism, I think, among physicians as well regarding this. And that has, I think, been a coping strategy that a lot of physicians have certainly held to. And it's something that we didn't expect in our generation, but it's a new thing and it's a new normal. But in the end, physicians are certainly used to going through adversity and climbing back out, and we will do the same with this as we've done in other scenarios.
That's great. And, I think that's an important point for the public to understand, because there's some irony there, right? You'd think that hospitals of all places are the ones who are financially stable and doing well, but that's not the case, right, for all doctors right now. So that's important to understand, that we should all thank you and appreciate you and all the essential workers on the front lines. So I want to go to some silver linings. The news is quite depressing, and a lot of the things highlighted are just very negative. So could you give us some positive medical news that we could take away from this?
Sure. And if you wouldn't mind, maybe I'll share my screen so I can show, one silver lining, which is what happened in California as an example. And then I'll go back to talking about it. So if you can see this screen.
We're MIT, so we love numbers. This is great.
Yeah. Can you see my screen here?
Yes.
So this is the current data as of last night, where you can see that, as we all know, the outbreaks in New York, and then by contiguity, New Jersey, and then by proximity, Massachusetts and other states, these states were the most heavily impacted, and certainly the exponential rise in New York was something that was quite horrifying to watch, and still is. And the numbers of fatalities that are stacking up there are still quite high. But as you go down the list, you see that California, which early on had very similar numbers to New York, but implemented social distancing just a matter of days earlier, but those days made all the difference. So California unfolded very differently, as have many other states. We also had a lot of concerns about states like Louisiana, because their healthcare capacity is much more limited. But that also, I think, is a cause for optimism. We're seeing that in a lot of the southern states where we feared pandemics, but where social distancing and sheltering in place has been implemented and has been messaged, I think it's been effective. So as we look at California, the hardest hit areas are in Los Angeles, and certainly in Northern California, our counties of Santa Clara, San Francisco, and San Mateo. We had a lot of very well-founded fears early on, but distancing was implemented quite early, and we can see that the numbers did not scale up, luckily, to what we expected. So there are silver linings in this, and if I show the next slide, which tells us that when we mandated social distancing, which was again only a few days before New York, but that made all the difference. And the number of resources that we have in California to be able to absorb and care for these patients, we have a lot of capacity, and we built out more capacity in that short period of time. And so if we walk through what the curves in California look like now, so this plot shows us what the capacity is in California, example for hospital beds, and what actually happened in California regarding the beds that we were using on a daily basis, and what the expectation is given the current pandemic. And this is the curve as of last night. If we had looked at this curve a couple of weeks ago, which I did, I've been looking at this curve every day, we expected the peak in beds, in the use of ICU beds, and the use of ventilators. We expected that, initially we expected it mid to end of May. Then it was shifted to early May, and we expected the peak to happen then. And now we see that the peak is actually today or tomorrow. And so we expect now that our peak number of cases, the number of cases stacking up every day of new infections is going to happen in the next couple of days, meaning that we are on the downhill from that point onward. And I started developing that optimism probably about 3 weeks ago, when I started seeing that the number of cases that came into Stanford Hospital that I was caring for were rapid early on, and then became fairly consistent. And we would get 2 to 3 to 4 cases a day, and it would remain that way for days on end. And we would be able to turn around many of those cases pretty quickly. And if we look at the amount of capacity we have in California, and in our hospital also, the capacity was much larger than what we needed. If we go on to ICU beds, we see the peak is quite similar in the amount of ICU beds we have in our state to be able to absorb these types of patients, if necessary, far outpaces the demand that is placed on our healthcare system. And the final thing would be the invasive ventilators, which was quite similar. So we have more ventilators in the state than we would need to absorb what would be required of this type of pandemic. So that would be one silver lining I would offer, because that's been duplicated in many cases across the country, is that because of the things that we implemented very early on, the irony is that we will not directly see the fruits of our efforts. We will see them in the absence of cases. And all the projections that we had very early on that were quite dramatic and quite concerning, but were very realistic in my view, those projections will not come into fruition. We probably will see the tens of thousands of deaths. Maybe we will reach 100,000. I think that that's probably realistic. But the scale of the pandemic, the number of infections, the amount of time that this is going to go on, I think is going to be dramatically reduced because of the things that we did. And it's in many ways, it'll be a thankless task, and there will be individuals who look back and say that we sounded the alarm bells too strongly and that we spoke too loudly. But it is precisely because we did those things that we were able to alter the trajectory. And so That is one silver lining. I think the other thing that I have a lot of optimism about is that the lessons that we learned from this will ring very true in the way that SARS left a burning memory and impression in those in Asia who experienced it, and who the next time that this happened, they were able to scale up and react very rapidly. If you look at the case of Singapore, who learned from SARS, they had very few cases, and they were able to implement a containment strategy, isolate and identify every individual who has an infection for 14 days. They did that very early on and very effectively. And I feel that in this country, the next time this happens, we will be prepared in many ways, whether that's public-private partnerships, being able to rapidly scale up hospitals, be able to deploy testing. We will be able to do that in a much more nimble way the next time because we learned from this pandemic.
Right. So it sounds like California, with Governor Gavin Newsom and Californians adhering early to this, that this work paid off. Is that fair
Absolutely.
to say?
Absolutely. I commend that decision. And obviously it's a difficult decision to make, and it has a lot of consequences. And it is hard, I think, for many individuals to understand, because if a disease is largely asymptomatic and 80% of cases are mild and almost no one with the disease needs to go to the hospital, why do we have to stay at home? And why do we have to start working? And why do we have to turn our lives upside down? And in the end, it has cost a lot as far as resources, and certainly in productivity, and families have sacrificed and they've been stretched thin. And it is primarily to save lives. And that's what I would say. The goal was to save lives, and we've done that. And then the rest of it, we have to reconcile, and we have to bring things back online and get people back to work and help us recover what is quite frankly devastating economic consequences. But we, as a society, had to make that trade-off, and I think we made that decision properly.
Great. And Sudeb, you had mentioned that looking back on this, there will be those who say, oh, we sounded the alarm too much, this wasn't as bad. This is obviously not taking into account the but-for world, right? What would have actually happened if we didn't do this? It would have been millions of lives, not tens of thousands of lives. So, you know, and anything that you want to say, you know, fast forwarding to those who are making that criticism in the future.
You know, I would say that, as I mentioned before, it always is a trade-off. And you could always make the argument that the economic consequences also cost lives and also cost a lot of other things that we will understand as we do the analyses moving forward. And so the idea of saving lives directly, but potentially losing other things indirectly, or disrupting supply chains and having people struggle and not having enough food, these certainly are the things that we need to contend with. And I certainly welcome the opportunity to participate in those conversations to understand what the other perspectives are, and what the disruptions really were, and what those impacts are, so that we can make informed decisions in the future. It's certainly one perspective, the perspective of the physicians, the epidemiologists, and the public health folks, that lives first, and then we deal with the consequences later. But I will say that in this case, given the type of illness that we were dealing with, and again, all the experts agree that the unique properties of this illness were its transmissibility, its fatality rate, which was right in that sweet spot where you don't kill so many hosts that you burn out, but you kill enough people to be able to potentially kill millions. It was right in that niche where we worry the most about these kinds of illnesses, as well as what we've learned from prior pandemics. It was the right response. And I certainly would be happy to entertain those kinds of conversations, but at the same time, we need to be able to weigh all of those factors with every pandemic. We need to be able to make those decisions, though, very rapidly. And so in many ways, I would say that the response here probably overall, nationally, was not early enough. And certainly we can alter dynamics of epidemics in many other ways, not just distancing and not such harsh measures. And I think that there are many lessons that came out of this pandemic in particular that help us alter trajectory in other ways that are probably less costly and help us arrive at more reasonable and well-informed decisions in the future.
Wonderful. Thank you so much, Dr. Dalai. We've learned a lot of things through this conversation, covered a lot of topics from how to make your own mask and what those best practices are to really reinforcing our understanding of some of these epidemiologic terms. Thank you so much. Your well-being is our well-being. Thank you to you and your wife and everyone on the front lines right now fighting this pandemic. And we hope we can meet on the other side.
Great. Thank you so much for having me. And please, you know, I welcome the MIT community to reach out to me at any time for any reason. I'm happy to help.
Wonderful. Thank you, everybody. Stay healthy.
Thank you.
Wash your hands.
Take care.